All right, let's get this done. All right, first part of your video is going to include slides 1 through 20 that talks about your rheumatic heart disease, all of your atrial mitral valve stenosis, regurgitation, mitral valve prolapse. Yes, I will do a review video that will be a third part that's going to help get hopefully some understanding. That's a lot of information. So just be mindful. You have to know what's normal, what direction the blood flow is going, which valve is it going through, where did it come from, and where's it going to. So those are important things to remember, as well as where are you going to listen to these heart sounds. So we just talked about aortic. So where is the aortic valve? Where can you listen? Where are you going to lay your stethoscope on that chest and listen? The pause is for you to think and say it out loud to yourself. Aortic is right side, second intercostal space, that space between the ribs. Pulmonic, left side, second intercostal space. I'm going to jump to mitral because we just talked about those two. Mitral is left side, fifth intercostal space, mid-clavicular line. So cut that clavicle in half, move down to the fifth left intercostal space and lay your stethoscope there for a mitral valve. Aortic and mitral, know where they are. You will see it again. All right, so now let's move on. We're going to combine a little bit of review here. So valvular disease, we just talked about several. Diagnosing them, medical treatment for them, and some similarities for a lot of them, the two that we talked about, aortic and mitral. So when we take a history and physical, we need to know what's going on with these folks. Slideshows start. You can see the slide better that way. Okay, history and physical findings. What did we find when we talked to them? What complaints did they have? Are these folks complaining of dyspnea, orthopnea, paroxysmal nocturnal dyspnea, dyspnea on exertion? Where is their dyspnea? Are they short of breath? Are these new symptoms? Are they gradual? Have they been coming about for some time? So some of the disease processes with these valves don't have any symptoms. They're asymptomatic in the beginning, but they end up with lots of different symptoms. So knowing that, like I said earlier, where that blood came from and where is it going, is going to make a huge difference in how you understand them. So if I'm coming back to the left side of the heart, I'm coming from the lungs. So backing up there, I'm congesting my lungs, so I'm going to have fluid buildup, right? Dyspnea, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, exertion, no shortness of breath. Am I anxious because of all of that? Possibly so. Do I have dysrhythmias, depending on where my valve issue is? Am I having anxiety? Remember, we talked about those. I'm going to get an echo on just every single one of them. And the echo is going to help diagnose the valve disorder, the valve disease. And some of these are going to be done through a TEE. A TEE is a transesophageal echocardiogram. If you get an opportunity on your cath lab rotation to see one, jump in there. Tell the cardiologist you want to see one and tell them why, because we're learning about valve disease. I know every single one of those cardiologists up there will just put you under their wing and take you right in, and they will help you learn. I know they will. So we're going to do EKGs. So if we have some left ventricular hypertrophy, I know you guys don't know a lot about EKGs. Ms. Kofke's taking you through rhythms, but on that EKG, you learned what ST elevation was. So you can learn that left ventricular hypertrophy are going to be tall R waves. The amplitude of that R wave trying to push out from the left ventricle to the aorta. You're going to see them in your V leads. Chest x-rays, you're going to see big hearts. If you ever knew Dr. Lay, he would say, sick hot, sick hot. They're going to go to the cardiac cath lab. We're going to look at the pressures in each area that we can, each chamber, left atrium, right ventricles, all of them. Right side, left side, atrial ventricles. We're going to see them all under the cardiac cath lab. Different procedures, but we can see them all. So there are non-surgical managements. We're going to talk about those. And there are surgical management. We're fixing to get into those. But non-surgically, these folks need to be diet, cholesterol, triglyceride, caffeine controlled, compliance, drug therapies. Remember, there's caution of calcium channel blockers. And one of these disorders, go back and look. That way you learn and you remember. Prophylactic antibiotics. You're going to be using those with folks rheumatic heart disease, prolapse, mitral valve, and there are other ones for any dental work or pre-procedure on some things. Most of these folks are going to be on a beta blocker, decreasing the workload of the heart, decreasing the oxygen need for the heart, the supply and demand. Calcium channel blockers, we're going to see those used. ACE inhibitors, diuretics, and digoxin, that contractility. We're going to manage their atrial fib or their ventricular fast rates. Atrial fib has a tendency when you get anxious or you have issues with your heart to go really, really fast, and we have to slow you down. Cardioversion or control the rate. And if you're atrial fib, you need to be on anticoagulants. You guys know this. So prophylactic antibiotics, there's penicillins to help treat and keep the bacteria away from those heart valves. Valvular disease, nursing assessment and interventions. Neurologically, are they having syncopal episodes? What is their neurostatus? Are they alert, oriented? Are they tired, short of breath, not sleeping well? Level of consciousness, dizzy. Cardiac-wise, the vital signs. The blood pressure is going to tell you a lot. And the rate and the rhythm of their heart. Their heart sounds are going to tell you a lot. We're learning to where to put our stethoscope on the chest to know what to listen for in the different valve areas. So hearing extra sounds, if you hear something in clinical, grab your faculty or grab somebody and say, hey, come listen with me. We need to know what this is. Grab a cardiologist. I'm telling you, do it. Heart pressures, cardiac cath lab, EKGs, and then we are going to know from our baseline how it's advancing from the different procedures that they are getting, the cardiac cath lab, the chest x-rays and things like that. Tissue perfusion is a big thing. Echo, echo, and echo cardios. Respiratory, we need to check their respiratory rate. We need to look at their rhythm of breathing. We need to know if they're short of breath. Did they just walk in from the parking lot to your office and you're assessing them? Or did you just walk in and you got them up and you walked them down the hall and you come back to the room and you look at them and they're so short of breath, they can't breathe. So breathing, respiratory dyspnea, orthopnea, shortness of breath, O2 sats are going to tell you a lot. And lung sounds, are they having those crackles? Do they have that extra fluid volume on board? What kind of diet are they on? We've talked about that. Low cholesterol, low triglycerides, low sodium, caffeine, reduction, weighing daily, each time, every day. Early morning, what goes in must come out. So we need to know what their eyes and nose are, and we need to know we may need to restrict their intake. Chemistry, CBC, liver labs, cholesterol, triglyceride labs, we need to know all of those. Is everything functioning the way that it needs to function and what's normal? So nursing care for these folks, if you are taking care of a client that you're walking around and you bring them back to the room. Are they able to sit up in the chair? Do they have lower extremity swelling? Do we need to elevate their legs? Their head of bed needs to be elevated. Are they on oxygen? Do they require oxygen? And are they taking their medicines as they're prescribed? Do they have emotional support that they need? Do they have family support? Then multidisciplinary comes into play here. So we need a cardiac consult, a cardiac expert. We need a respiratory expert because our pulmonologist, somebody that can help us, guide us in these directions. Infection control, maybe if they're having issues with reoccurring infections. Then multidisciplinary also, we may need a discharge planner. We may need a social worker. Is the home environment ready for them to go back? Nursing needs to teach them about the disease process, and if they don't take care of themselves, their condition or the disease process can get worse. Do they need home oxygen? Are they able to afford their medications? Are they able to afford their insulin that they have to take care of their sugar? Lots of things for nursing to think about. Expert consults, multidisciplinary. Medical surgical treatment. So when we get to the point where these folks are not tolerating what we just talked about, they need to have a valve replaced, valve repaired. So there are certain things that we can do before we do replacement. Repairing them is typically a surgical procedure of choice in cardiology. So there are surgical therapies for valve repair or placement. Before we replace them, we can try to repair them through percutaneous balloon valvuloplasty. Take it onto the cath lab, taking the balloon plasty, opening up that stenotic valve that needs to be opened. A commiserotomy is then opening the stenotic valve as well, where they go in, and you'll see here in just a minute, because yes, Ms. McHargue has included you a video to see. Anguloplasty, remember we talked about that annulus ring that holds that valve in place. So we may need to work on getting that ring replaced. There's going to be pictures coming. And then lastly, but not leastly, we talk about replacing those valves. Is your patient stable enough to go to the OR, to be put under anesthesia, and to have these valves replaced? They sometimes are, and sometimes there are folks that are not. So the first three that are mentioned here, percutaneous balloon valvuloplasty, commiserotomy, which would be an OR procedure, and anguloplasty, we need to think about what quality of life we are looking for. So let's go back to valvuloplasty as a repair rather than a replacement. Benefits: the patients do not require continuous anticoagulation, and the balloon procedure can be done in the cath lab. Light sedation, monitor, send them back to critical care or to telemetry wherever they are. Some folks can go home. So commiserotomy is a type of valvuloplasty procedure. Each valve, remember I said in the beginning, has leaflets. Mitral has 2, tricuspid has 3. So, and this is where they meet in the middle. It's called a commissure. So we need to open them up. Remember the mitral valve stenosis, and those valves, the commissures stick together and they need to be surgically divided or fixed. Commiserotomy is fixing stenotic valves. Anguloplasty is a repair of the valve. It tightens the annular ring, the annulus that holds the valve in place with tissue, reducing the circumference of that area, and it's helpful in valve disease with regurgitation. And then replacement is with tissue or mechanical valves. The goal here with surgical treatment is to relieve the symptoms the client is having and restore some sort of normal hemodynamics for this patient. Goal is to relieve the symptoms and restore some sort of normalcy normal hemodynamics. Not everybody's the same. They're not everybody's normal. Remember that. There it is. So here we look, valvuloplasty. So valvuloplasty, remember I said we're going to open up that area. This procedure is to improve blood flow through a narrow valve, a stenotic valve. A catheter is threaded through the valve and the hole temporarily created in the septal wall and inflated. So they have to go through mitral valve on this side, the balloon in the catheter. The procedure comes up through, go through the septal wall, and here they are trying to open up that mitral valve. There is a video to watch. So there is a nice looking valve. This one is a 3-leaflet valve. You should know by now which one that is. And this one over here is floppy, so we're fixing this area. And that's what it looks like in the OR. So in your notes section, you'll see a video. Valvuloplasty is beneficial for mitral valve stenosis in younger patients and aortic valve stenosis in our older folks. But we have to think about comorbidities and quality of life with our older folks. You can do this in the cath lab. So think about complications with this procedure. We've gone through the septal wall, so we could have worsening mitral valve regurgitation. We can have bleeding from the site, like a cath lab site, embolus or strokes, left to right shunts from the atrial septal hole right there. Not getting that pencil back out yet. Okay, so there that valve looks. What does it look like? That's what it looks like. They go in there and they inflate the balloon several times and they open up that area. So we're moving on. Commiserotomy. Where these leaflets join, it's called the commissure. It is an open heart surgery procedure, so you have to think about, is the patient able to go under general anesthesia to have open heart surgery? So this valve, we're trying to think about repairing the mitral valve. Where is the mitral valve? You should know by now. Left atrium, left ventricle. And it's narrowed from stenosis. What does stenosis mean? And so this procedure, commiserotomy, is used for patients who have severe narrowing. And they cut this bottom leaflet and they tie it back together to get rid of the area that's makes the leaflet stick or be able to open and close. So remember we said mitral valve has an anterior and a posterior leaflet, and the leaflets are held together by what's called the annulus ring. So with this procedure, the risk is it is an open heart surgery procedure. It is a sternotomy, open up the chest, put on the heart-lung machine, and any other of the surgical risk, bleeding, emboli, infection. Benefits is that we fix the valve, quicker recovery times, and they can be back to activities as they were in 4 to 6 weeks. They cannot lift heavy objects when they go home, and they need to follow a heart-healthy diet. No smoking, take your meds, reduce your stress. Sounds monotonous. So multidisciplinary, we have the nurse to teach, to talk, allow the client to talk, have some kind of control, cardiac rehab, physical therapist, and they open that chest wall. That's what hurts. So anguloplasty, here we're fixing the annulus ring. And if you look right here, we see a damaged, where's my pencil? Kofke, you're going to make me learn. So looking right here, I'm seeing this damaged valve leaflet. So we have to fix it. And we need to repair that annulus ring. Remember that annulus is what holds that valve in place. So this one again, the anguloplasty, this type surgery is a general anesthesia. And are they able to withstand surgery? Are they able to withstand cardio bypass machine? And they need to be on anticoagulants for 3 months. Heart valve surgery. There's a video. Mechanical valves, there's different types. If you have a mechanical valve, you're going to need anticoagulants. Tissue biological valves. These valves, let's back up to mechanical valves needing anticoagulants. They have long-term durability, and they put the client at risk for thromboembolism, so that's why anticoagulants. Prophylactic antibiotics prior to procedures, especially dental. Teaching good oral hygiene. Biological valves that you see listed here, we'll see pictures. They have a poor long-term durability. So again, same teaching, same problems. Xenografts are heterographs. They come from other species, cow or pig. There's no blood typing necessary. Studies show improved longevity for these type valves if they do use correct blood typing. We can't do that with animals. So then homografts and allografts are human valves from donors. And autografts is a valve that's translocated. An example of that is a pulmonic valve used for an aortic valve. And there's a video, in this video, they take tissue from the pericardium and create a valve. All kinds of things they can do. TAVR. I've seen Dr. Jim Zachariah in the Cardiac Forum conference that goes on every year. He talked very in-depthly about this TAVR procedure. When all other repairs and treatments fail or don't work, warranting a total valve replacement may be necessary. And there's a way they can do it, this TAVR way, that doesn't require them to have an open sternotomy. Robotics help. There's less bleeding, less scarring, less infection rates. The valve leaflets are removed, but everything else is left in place, and they can go in and they can change that valve. It's, as you see, through the chest wall. None of this. Open heart. TAVR. Transfemorally, transapically, that they can go in through the chest wall. Transaortic. TAVI stands for transcatheter aortic valve implantation. It's used for clients who are not good surgical candidates. Performed in the cath lab. Interesting. So mechanical valves, here's what some of them look like. To the left, we have a balloon in a cage design. It is more durable and used in younger folks. They last longer. On the right side is a bileaflet valve. These folks have to be on anticoagulants on this side right here forever and ever. So what do we have to teach them when they take anticoagulants for long periods of time? They need to have their labs checked. So with the Coumadin or warfarin mitral valve, you want their INR between 2.5 and 3.5. And with an aortic valve, an INR of 1.8 to 2.2. These are more durable than tissue valves. Here's some tissue valves. They are preferred for women during childbearing ages. And clients over 70 with peptic ulcer disease or GI bleeds that can't tolerate long-term anticoagulant therapy. Collaborative interventions with these folks. So we'd have a cardiologist, interventionalist. So what are we going to teach our clients about mechanical and biologicals? They last longer and require anticoagulants. And biologicals are cow, pig, and human tissue with no anticoagulants. And they do not last as long. These folks are going to go to ICU postoperatively. Cardiac monitoring, frequent vital signs, as you'll see in the critical care, assess for heart failure, symptoms, and emboli. So if we got a patient back from the OR that went to have a valve replaced, and they come back to you and you're doing your assessment, and their feet are cold and they don't have any pulses, what happened? They threw a clot, right? You need to listen and assess for those emboli, changes in heart sounds, their neurological status, their incision sites or insertion sites. You're going to have drips to maintain blood pressures for increasing and decreasing. Good oral hygiene to prevent infections, teaching them about anticoagulants, self-care, labs, diet, meds, compliance, and that weight gain. Okay, we're winding down, believe it or not. Auscultating heart sounds. This is a different kind of slide. I like the first one, the 5 areas of listening to the heart in the very beginning, but this one is a one that I found as well. It's called APE. The aortic, pulmonic, tricuspid, mitral. Doesn't include herbs, but go to that first one that I included with the little gentleman reading All People Enjoy Time magazine. Just something else for you to look at. And this is what I feel like after recording these lectures. This heart is taking a deep breath. Did anyone else hear that, or was it just me? When you're listening to heart sounds, you want to hear the lub dub, lub dub, lub dub, lub dub, lub dub. You want to hear that open and close, systole, diastole, valves open, they close, they open, they close. If you hear something that's lub dub dub, lub dub dub, lub dub dub, that's not right. Or I can't do an S4, but you can march it out. Lub dub dub, lub dub dub, lub dub dub. So when you hear extra sounds, grab somebody and say, hey, did you hear that? Or was that just me? There's a murmur there. I need to let somebody know. The causes of heart murmurs are the acronym of spasms, stenotic valves, a partial obstruction of those valves, regurgitation of aortic or mitral, and a septal defect. We see those septal defects in kids. Systolic and diastolic, need to know when the valves open and close, pushing blood through. Don't worry about crescendo and decrescendo. Too much other stuff to worry about. And then innocent murmurs occur in children or with pregnancy and are noted, documented in their chart during systole. Stop sharing. Okay, that is the end of this content. Perfusion, valves, rheumatic heart disease, and acquired valvular disease. You have some work to do. I'm going to help you get through this. Aortic, mitral, Erb's point. You need to know where they are. You need to go ahead and learn pulmonic and tricuspid. Where does the blood travel through the heart? That's in the slides. Comes in the right side, goes through what valve? Into the right ventricle, what valve? Where does it go? To the lungs. So it leaves the lungs, it's coming back to the left atrium. Where is it going to go through what valve? Into the left ventricle, out the left ventricle to the aorta through what valve? make you a song, make you something that you can remember them by. Each valve can be or have stenosis or regurgitation, mitral valve prolapses. Okay. Don't get bogged down. Email me. We can talk through this. We can get through this. We'll do it. You can learn it. All right. Have a good evening, and I'll see you in the morning.